Good evening, everyone. I'll be presenting a case of eyelid defect today. I was given this case of a 7-year-old boy who's a resident of Kochi who presented with post-traumatic loss of the right upper eyelid around 7 days back. The history that I would want to ask is I would want a detailed history of the trauma itself, basically where it occurred and the object on which he had fallen, following which there was traumatic defect. And also, I would ask for any visual problems like diplopia, any obscured visual field on the right, on the injured side. Also, history of epiphora like excessive watering from the eye, or symptoms of dry eye like itching, etc. Also, I would ask for any history of previous surgeries, and also at the time of trauma, what exact treatment was given, whether any surgical procedure was done at the time of trauma itself. Coming to the past history, no comorbidities were present, no habits were present. Coming to general physical examination, there's no evidence of pallor, no icterus, clubbing, cyanosis, lymphedema, etc. Vitals were found to be stable. Coming to local examination, on inspection, this is only pertaining to the right side. Basically, there's a full thickness defect of the medial, approximately medial 2/3 of the right eye, right upper eyelid. Also, there seems to be loss of the eyelid crease due to edema, and there also seems to be edema of the lower eyelid, minimal edema, and also a small scab on the right infraorbital area. Small healed abrasions are also seen on the right side of the forehead. Nothing to show any deep injuries. And during inspection, I would also want to check for the retractor and protractor function of the eyelids. Coming to the palpation aspect of it, there was no evidence of any tenderness, no evidence of any local rise of temperature. I would like to confirm all my inspectory findings. And if possible, I would like to take accurate measurements of the eyelid defect itself. Also, I would like to examine for the donor sites, that is the lower eyelid, the opposite eyelids, the forehead, etc., to plan my treatment. Coming to the diagnosis, I would like to, my diagnosis would be a post-traumatic full thickness defect of the right upper eyelid involving the medial 2/3 of the upper eyelid. Ma'am, should I go ahead with the investigations part of it?
Okay. You can go ahead with the investigations and your basic plan also. After that, we'll just take one by one and discuss in detail. Okay?
Yes, ma'am. So investigations, first of all, I would like to get routine blood investigations for fitness for surgery. Other than that, I would like to get visual acuity examined for each individual eye. Also, Shermer's test to check, to rule out dry eye. Fluorescein dye test to check for any corneal scarring, etc. And intraoperatively, I would like to check, since it involves the medial half of the upper eyelid, I would also like to check the patency of the nasolacrimal duct if any necessary intervention is needed. But this would probably be possible only in the intraoperative setting. So now coming to the treatment, based on my investigations, the treatment, I've come up with 3 different options to reconstruct the upper eyelid. My first option would be a cutler beard flap from the lower eyelid itself. The whole purpose why I would put this as my first option is to replace like with like, so that I can recreate both the anterior and posterior lamella in one sitting itself. And my second option would be a laterally based Fricka flap, to create the anterior lamella, and a palatal mucoperiosteal graft to create the posterior lamella. My choice of the palatal mucoperiosteal graft is because otherwise I would have to take a separate either I would have to take a composite mucochondrial graft, or I would have to take a separate cartilage graft. Again, the Fricka flap would be a thicker flap compared to the eyelid skin itself. So all this would add to the thickness. The palatal mucoperiosteal flap, the graft would give us some kind of stability because the periosteum being taken with the graft.
Shravana, we can come back to why you chose each flaps in course of the discussion. Okay.
Okay. Okay.
So can we now go back to your history part?
Yes.
Right. So eyelid cases as such will be kept only as a short case.
Yes.
And most frequently it will not be an acute trauma. You can expect that it will be some congenital defects, like a coloboma in a child can present it the same way. So it can be a coloboma in which your reconstruction might be on fairly the same course also, or it can be some tumors in an older people, and after post resection you will be you'll be planning some reconstruction.
Yes, ma'am.
So I understand that you've not been provided much detail about this child. So we gather that this is a young child, 7-year-old, otherwise fit medically, and he has sustained a injury to a traumatic loss of the medial 2/3 of the upper eyelid on the right side.
Yes, ma'am.
So that part I understood. So any detail that you would like, anything more that you want to know about this patient? So a young child who has had a fall.
Yes, ma'am.
You asked about the medical history, right?
Yes, ma'am.
Is there anything in particular which you have in mind when you're asking about fall and this kind of magnitude of injury in a small child? Specifically, do you have anything in mind?
Exact details of how the fall occurred, if there was a loss of consciousness and fall, or if while playing it happened, and also
suppose this case is there for your exam. You have the actual patient and the informant is the mother. So in that case, do you want to ask anything more in the history? You asked about medications, so regular medications. So do you have anything in mind that the child can fall like this and sustain injury? Seizure disorder?
Seizure, yes, ma'am. Any seizure disorders? Yes, ma'am.
That is very important because this is going to affect your management also. So you have to think about getting the relevant consultations and getting him ready for anesthesia.
Yes.
And having multiple surgeries for this child, so single stage or multiple stage, that will be affected by the history, right? And like that, on some medications also, you'll have to ask. So normal faculties are there. He's not retarded. He's not having any other physical disabilities. That's what we are presuming, right?
Yes.
Actual history of this patient is slightly different. He is actually from Karnataka. He is a guest to Kerala. So he is staying here for a short time only with the relatives. Now he is about to go back. And this happened because of a dog bite.
Oh, okay.
Right. So this is just to add to the history only. So small children, they might be having, they can be mauled by dogs also.
Yes.
Situation. So in this new information,
yes,
how will your management differ? Can you tell me a couple of things which will come to your mind if the history is given like this?
One thing is, ma'am, I would like to know details about the animal that had actually caused caused the attack. One is if it's vaccinated or not. One more if it's a if it's a stray dog or if it's a house-owned dog. If in case they're unsure about the history about vaccination, then the child needs to be vaccinated with anti-rabies. And also, while debriding the wound will have to be irrigated with immunoglobulins.
Actually, wound edges can be infiltrated with immunoglobulins also.
Yes.
Right. So, how will it affect your surgery? So, the social and preventive medicine department is taking care of the immunization aspect. And
Yes.
this will be what class of injury?
Ma'am, this facial bites are the highest grade of.
Yeah. So hand, face.
Yes.
Will be class 3, right?
Yes. So you can't immediately reconstruct.
Exactly.
Also, you'll have to wait. Yes.
What are the problems of immediate reconstruction?
Immediate reconstruction. One thing is, ma'am, you're not sure about clearing out the contaminants. And one more thing is you're closing off an open wound, which would have helped the child. If it's left open, it helps in treating or not getting basically the rabies itself or something like that. Basically, to let the wound drain out.
So in rabies, why don't you close it primarily immediately? You do a delayed primary repair, right?
Yes, ma'am.
You cannot do an immediate reconstruction like in a trauma. You will have
Yes.
to opt for a delayed primary reconstruction or a delayed reconstruction.
Yes.
That is because when you're closing the wound under tension in a class 3 wound,
yes.
It is said that the rabies can be when rabies will a virus can gain entry into the nervous system faster in a closed wound.
Yes.
That is one thing. But what SPM department is advocating now is that after 48 hours after you've given the antiglobulin infiltration and the ARS also, then you can take up this patient for surgery. So you don't have to wait as long as you used to in the previous days, right?
Yes. Yes.
Okay, and like you said, the contamination, of course, from the saliva will be there. So we have to do a good debridement and then only close the wound to prevent the infection in that case. Right. So that is how your management will differ according to the history that is given. Okay.
Yes, ma'am. Yes.
So now after you have cleared that this vaccination everything is done, debridement is also done properly. Patient has got antibiotics.
Yes.
Then you have to assess the defect now, right?
Yes.
So how will you assess the defect? What all structures are actually gone? And roughly how will you be able to measure the defect? How much is the defect in terms of length and breadth? How much will it be in terms of the structures that you have to give back?
Ma'am, you'll have to use the opposite eye as to actually measure the true defect.
Okay.
So based on the normal side, it would be better to assess because the affected side itself will be very edematous and there'll be disparity in your measurements.
That will be there, and little bit of retraction of the remnants of the lid will be there towards the lateral canthus.
Yes.
Because apparently the medial canthal attachment is gone.
Yes.
Right? So it will be more pulled towards the lateral side now. It will be bunched up on the lateral side. That also you can see. So agreed. So normally, what is the intercanthal distance if you're measuring from medial canthus to lateral canthus? Not in a child. Let's say in an adult. How much do you expect the breadth of the eye to be?
Medial to the lateral canthus, the
Intercanthal
horizontal.
distance we call, na?
Yes, ma'am. That will be approximately.
Have you heard of rule of 30? I think we've had this discussion for ptosis also, where it is more relevant.
Yes, ma'am.
When there is a medial
30
fold and you want to correct that,
yes.
in that case also you have to take these measurements.
Yes.
It is called something roughly, it is called a rule of 30,
Yes,
where medial canthus to medial canthal distance across the root of the nose, that will
yes.
be 30 millimeters.
Yes, ma'am.
Right? And from medial canthus to lateral canthus, it will be 30 millimeters.
Yes.
So from one pupil to the other pupil, so interpupillary distance between the two pupils, it will be double of this, right? Is it?
Yes.
Because middle 30, then half on either side, 15, 15. So it will be 60 millimeters.
Yes.
Okay. So this
Yes.
is an approximation of the length that you're getting. I mean the width that you're getting, and in that you will have to pull on the edges and then determine how much is the actual percentage. But roughly you can say that this is somewhere. How do you say the defect? How do you in, you say it in percentages, right?
Yes, ma'am. Percentages would
So
be ideal.
yes. So
Yes, I
you say that. How do you calculate how much is lost?
approximately 60% would.
So definitely more than 50 is lost.
Yes,
Yes.
yes, ma'am. More than 50.
But you get a total idea only when you're putting a suture on the net margins and we're pulling and seeing, assessing the total defect, right? Because the
Yes.
tissues are retracted on one side.
Yes.
Okay. Suppose transversely it is 60% agreed. So it is a major loss of the upper eyelid.
Yes.
Vertically, how much do you think?
Vertically.
You have a prominent landmark there, above
Yes.
which it is normal, below that only the tissue is lost. So what is that prominent landmark you're seeing? There's a fold there.
The crease, ma'am. The eyelid crease. That is the most prominent landmark on the upper eyelid, ma'am.
That will correspond to supratarsal fold, right?
Yes, ma'am. Yes, ma'am.
So you know that tarsus is firmly attached to the outlying structures. The skin
Yes.
and orbicularis are very attached there over the tarsus. And
Yes.
above that, the skin and orbicularis part is looser.
Yes.
So even with the edema, you can see that there is a marked supratarsal fold there.
Yes, ma'am.
So above that fold, the structures are normal. Looks like.
Yes. Yes.
Yes. So below the supratarsal fold, it is gone.
Yes.
So then you know that what all structures would be gone now.
Both the anterior and posterior lamella would have gone, ma'am. Basically, the skin's orbicularis, the tarsal plate, and the mucosa behind, all of them would have gone.
So what is anterior lamella? What is posterior lamella?
Anterior lamella is basically the muscle and the skin, ma'am. And the posterior lamella is the tarsal plate with the mucosa.
Which muscle is it?
Orbicularis, ocular muscle.
Orbicularis. Okay. So how many parts are there for orbicularis?
Three parts are there, ma'am. Preseptal, pretarsal, and orbital.
What is the function of orbicularis?
Basically, it closes the eyes, ma'am. Forceful closure of the eye is caused by the orbicularis.
Oh, so that is closure. So what opens the eye?
It's the levator palpebrae superioris along with the molars muscle, but majority of the function is by the levator palpebrae superioris.
So, and what causes eyelid opening? Is it the upper eyelid or lower eyelid?
It's mostly the upper eyelid, ma'am.
How much percentage is upper eyelid?
That I'm not sure.
90% is roughly upper eyelid and only 10% is contributed by the lower eyelid. So
Yes.
that is contributing to our reconstructive dilemma, right?
Yes, ma'am.
We are supposed to give not only the structure,
Also
but
function.
the movement is
Function.
also very important because otherwise it will be like a curtain falling
Yes.
over the pupil.
Yes.
So if you're giving a very heavy kind of reconstruction for this is right over the cornea of the child, right?
Yes. Yes, ma'am.
So if you're giving a very heavy reconstruction in that area, then the child will not be able to
See.
see also.
Yeah.
So that in a developing eye is going to be a problem,
Yes.
isn't it? So we
Yes.
have to give a more functional kind of reconstruction where the child will be able to lift up the eyelid and clear his pupil for the visual access.
Yes.
Agreed? Right. So you said anterior lamella is gone below the supratarsal fold, that is, the skin is not there and the opposite
Orbicularis.
is there.
Yes.
Then the tarsus is also vertically gone, and opposed to that, the conjunctiva is also gone.
Yes.
Right? So
Yes,
how
ma'am.
much vertical height of the tarsus would be gone? Will there be any remnant of the tarsus from this picture?
I don't think there would be any remnant tarsus, ma'am, because approximately 4 would be the height of
For upper eyelid?
uh, lower eyelid, I think.
Upper eyelid or
But
lower eyelid tarsus is bigger?
so the upper eyelid, I think the tarsus has is gone in the trauma itself.
Upper eyelid tarsus is bigger actually. It will be around 25 millimeter because that is giving the shape of the entire eyelid. It is
Yes,
curved over the globe. So that is the shape and contour is given by the hyaline
tarsus.
cartilage of the tarsus, and so it will be around 25 millimeters wide, and vertically it will be 8 to 10 millimeters in the midline for upper
Okay.
eyelid.
Yes.
Okay, so that much is gone. So entire width of the upper eyelid is gone, and the lower eyelid is shorter. So it is around 3 to 5 millimeters only. Like you said,
Yes.
4 millimeters will be the vertical height of the lower tarsus because
Yes.
it just reaches the limbus,
Yes.
right?
Yes.
So you need to reconstruct anterior and posterior lamella, and you also need to reconstruct the conjunctiva,
Canthus.
right?
Yes.
Because it's over the cornea. If it
Yes,
was
ma'am.
for the lateral aspect, little bit rough surface on the underlying of the lid would have been acceptable.
Mm.
If it is right over the cornea, you have to
Causes.
ensure that there's no corneal irritation, right?
Yes.
Okay. So, and it is on the medial side also, not on the lateral side.
Yes.
Fine. So, what are your goals now? Can you tell me, from what we discussed, this is a young child, a
Yes.
developing eye. So,
Uh,
what will be your goals of reconstruction in this child?
My primary goal would be to restore adequate eyelid function, ma'am. That is eyelid function in the sense it adequate eye opening and also adequate eye closure.
Yes.
Eye closure so as to protect the cornea. Also, also because of closure, it causes adequate spread of tear film, and that also has protective function on the eye. My secondary objective would be to restore the aesthetic part of the eye, ma'am, because that it's always behind the functional aspect, but
Yes.
secondary aspect would be that.
So, structure which is functioning, and then finally only the aesthetics and symmetry with the other eyelid will be coming.
Yes, ma'am.
So that is your goal, and then can we go back to your plans?
Yes.
You made the 3 plans, so can you justify why you chose these plans?
Yes, ma'am. First plan I thought would be cutler beard flap from the lower eyelid, ma'am.
Yes.
There's one drawback with this treatment plan because that it's two-staged. Considering that it's a child who's going to be non-cooperative and who may not be you'll have to basically wait for a 6-week period to plan the second stage. So you'll have to temporarily close the eye when you're doing the cutler beard flap. So that is one drawback. But the main advantage with this would be that you are getting light tissue. So basically, that is why I chose. And you don't have to create a separate posterior and anterior lamella. You will be creating it, that you'll be taking it completely from the lower eyelid itself. So that is why I chosen cutler beard as the first option.
So can we discuss about this plan first?
Yes, ma'am. Actually, I've made a slide, ma'am. Basically, the cutler beard flap is from the lower eyelid. Marking is basically after identifying the defect size and the defect dimensions. The flap is marked on the lower eyelid approximately 4 away from the eyelid margin, and it's marked approximately 2 more than the defect that is noted. So,
Why do I
one second.
then the defect?
Sorry, ma'am.
Why do you want to? So you said that is 4 below the. You're creating a bridge flap, right? The
Yes, ma'am.
bridge of the lower eyelid.
Yes, ma'am.
below 4 mm, you are taking a rectangular advancement flap with Burroughs triangles. Agreed. So what you all said that it is going to replace the posterior lamella. So can you give it one more thought? Is something going to be lacking in this? What are the two components of posterior lamella? What will be lacking in this in this design of cutler beard? Think about the anatomy. Hello?
Ma'am, can you hear me now?
Yeah, Shravan, yes.
One second. Yes. Ma'am, the problem with this technique, another disadvantage that I forgot to mention is the tarsal plate won't be included in the.
We already said now 4 mm will be
Yes.
the vertical height of the lower eyelid. It is very short.
Yes.
So from where you're going to harvest this flap,
Yes.
it will be below the tarsus. So
Yes.
what will be lacking? The structural support of the
eyelid. Yes.
eyelid. That is a major part of the eyelid will be lacking with the
Yes.
cutler beard, right?
Yes.
So that will be a fallacy of taking cutler beard as a first plan. Is there any way of overcoming this? Any plan that you can do to maybe not as a primary procedure, you can do something as a secondary procedure also?
You can put probably use a cartilage graft later on, like a conchal cartilage graft later on, and
Be given as a sandwich secondarily. You'll have to split it and put it there. Otherwise, main problem would be at the free margin after you're dividing it, right?
Yes.
Then, so this is like it's shown in the picture. This is more appropriate for the central defects.
Yes.
Whereas our defect is more on the medial side. Not that we cannot do it.
Yes.
It is mainly described for the central upper eyelid defect. That's all.
Yes.
Then you said one more thing you had mentioned was that you have to take the flap bigger than the defect.
Yes, slightly bigger than.
Is it usually like that? Or is there any other thing which you do for the eyelid? Like somebody called, have you heard of Mustardi?
Yes, the lid switch using Mustardies.
He described so many things. He has done a lot of pioneering works and there are textbook also.
Yes.
Is there anything that Mustardi has said or?
When a Mustardi lid switch is taken, it's usually taken smaller than the defect now because that's also taken from the.
Shravan, madam is asking you the principles of lid reconstruction according to Mustardi. I think that's what she's trying to ask you.
He said he'll take the flap bigger than the defect in this.
Yes.
Okay, so is it always like that, or is there any allowances that we can do when we are planning any flap? Do we have to take it bigger than the actual defect? Suppose it's a total eyelid loss or a subtotal eyelid loss. So do you have to take a flap which is bigger than that, or?
Not necessarily, ma'am. Actually, the main thing would be to maintain adequate tension, and as long as you can achieve that, you don't need to take a bigger flap. And this eyelid laxity would help us take a smaller flap and use it to interpose into a larger defect.
How smaller? Because the same principle we apply for the upper and lower lip reconstruction also.
Yes.
Isn't it? So how is it? So like upper lip is also more difficult to reconstruct because of the anatomical
aesthetic
it is having. So how much is it? How much can we close primarily? That was my question. I'll rephrase it. There is a certain percentage of the lid tissue which will be able, because it's an elastic tissue, will be able to close primarily.
25% is what they've said for eyelid, for primary closure.
Upper eyelid. And for lower eyelid, even bigger defects can be reconstructed.
Yes.
Close primarily. So your flap reconstructions usually will be for the remaining 5%. Isn't it?
Yes, ma'am. Yes.
The defect you are measuring here as 100%.
Yes.
5% it will be amenable for primary closure.
Yes.
So then you will be planning the flap because these are all very precious tissues.
Yes.
So you can plan the flap for the remaining.
So this, yes, 3/4.
If you have anything to add here,
Yeah, Shravan.
Yes, ma'am.
Let
Yes,
us
sir.
say that you're going to do the cutler beard flap. So where would the incision, the lower lid incision, no? At what position would it be in relation to the lower lid margin, and why?
The superior incision, sir.
Yeah, superior
It's
incision.
approximately 4 mm away from the lid margin, sir.
Why is that?
That is because the main thing is to retain the vascularity of the.
Correct.
Of
Very,
the
very
eyelid.
true. Yeah. So that is again one very important principle. So what happens is, one big problem is that the total amount of the tarsal plate that you're going to get is going to be very less. So that is why this particular flap is not a very favorite flap of for reconstruction, right?
Yes.
And what about your in that particular picture, you could not tell anything. I mean, you could not see the what do you call it, punctum. Did you mention anything about the punctum? Because that is very important.
The nasolacrimal duct, no, sir?
Yeah.
Yes, I had mentioned it in the investigation that intraoperatively we would have to check the patency of the nasolacrimal duct. If in case there's any obstruction if there's any obstruction to the duct, then dacrocystorhinostomy would be required intraoperatively, so that there's no chance of epiphora in the future and there's adequate drainage of the tube.
Okay, fine. That's all. Sheetha, you can carry on here.